Set up basically the architecture for the next lectures, so just bear with me. It's a little dry subject, but if we understand it well, things will be much easier. I have no disclosures. So what is spine deformity? Spine deformity basically is any patient that has a deformity in the spine that you can see radiologically and diagnostic, either on coronal or sagittal x-rays. And this deformity is not associated with some isolated injury. It's more than one entity. So etiology, either idiopathic scoliosis that hasn't been managed, de novo or degenerative scoliosis, joint diseases or joint ankylosis, iatrogenic from a previous surgery that was not done or performed properly, or the patient itself has global hyperkyphosis. And these are just a couple of x-rays that shows that although flat back, or we think every time of deformity in terms of kyphosis or scoliosis, but it also can be in terms of hypo. Clinical evaluation, usually there's a lot of scores that we use. Functional scores are the main bulk to try to give it some kind of subjectivity. So the CF is considered a score. It's not directly to the spine, but it measures in general what other non-specific diseases and how it contributes to the disease itself. Another score is the ODI, and this is more towards the lower back pain and the ability of the patient to function either with or without disabilities. Our SRS score, it's a more comprehensive score, and this tends to look at the function, the pain, the self-limiting, and any mental issues that the patient may have. In terms of imaging, so imaging will divide into coronal and sagittal alignment. So in terms of coronal alignment, the coronal plane is the head and the spine and the pelvis. In a normal patient, always want to be on one line. But sometimes with some deformities or they tend to shift away. And the way to measure this is through the global coronal alignment. And this is basically a plumb line that's drawn through C7 and how far it is from the sacral line. Another method in the coronal is Cobb angle, as everybody's familiar with this. And this is more with scoliosis, but it also can be used in some kind of deformities. Moving on, sagittal balance, sagittal alignment, which is the major key player and role in some adult deformities. So in terms of pelvic parameters, the pelvic incidence is the angle that is created and is drawn from the sacral plate straight to the midpoint in a line between the midline of the femoral head. It reflects overall the fixed shape of the pelvis. In the past, we used to think that this is the fixed angle and it's not changed. Although in the last SRS, Dr. Linke begs to differ. We'll see what comes out of his studies and we'll look into it, but things change. Another pelvic parameters are the pelvic tilt. The angle is formed by a vertical line that's drawn from the axis and at the midpoint of the femoral head, and it usually averages between 16 degrees plus minus 6. Sacral slope, again, is another form of a line that draws through the horizontal line drawn along the sacral end plate. Again, it varies from 36 to 46 plus minus 8. It depends on which literature we read. So the main thing is pelvic incidence equals pelvic tilt plus sacral slope. In terms of spine curvatures, we subdivide it into the lumbar lordosis, which is measured between the L1 and S1, and it varies. The thoracic kyphosis, which is between T12 and T4, and then going back to up to the cervical spine, which is between C2 and C7. And again, this varies according sometimes to age and the position of the patient. In terms of global alignment, and this is the most key player when we look at deformities, there's a lot of global alignment lines and studies. Depends on which one you know and which one you're comfortable with, and how validated and how comfortable you're using. So you have to choose one and know it, and then plan your surgery accordingly. In terms of classifications, there are multiple classifications that have been established. They're out there. The most commonly used is the SRS, Adult Spine Deformity Classification. And this basically goes and it divides it into the type of the curve, and then it looks into different modifiers. We'll go into each one to see which one. So in terms of curves, so there's different type of curves. T-type curve, if the patient has a major thoracic curve that's greater than 30, with a atypical level at T9 or higher. If the curve is at 30, but it's T10 or lower, it's considered as a lumbar curve. If the patient has a double major curve, meaning having both that are 30 degrees, and if he has no curve. After that, the most important thing is looking at the different modifiers. And the reason we look at different modifiers is to plan our surgery and know what to address during our surgery. Because like we said, adult deformity is not just an isolated pathology. We have to address it from multiple forms. So the importance of the PI minus the lumbar lordosis is to measure the importance, because the surgical planning of our patient with a small lumbar lordosis relative to a large PI, it varies. You need to do more osteotomies, and you should take into account the amount of post-operative lumbar lordosis necessary to achieve your alignment. So if patient modifier, if the value is between 10, it's considered modifier 0. It's from 10 to 20, it's plus 1. If it's more than that, it's plus 2. Pelvic tilt. Pelvic tilt is a very crucial part of our modifiers. The reason it has a very compensatory mechanism that can affect and reduce the apparent global sagittal malalignment. So in addition to being a parameter, it has a very strong correlation. It's been studied and established that with the pain and disability that the patient has post-op. So pelvic tilt less than 20 is considered 0. 20 to 30 is a plus 1, and more than that is a plus 2. Another important modifier is the SVA, and this is the global alignment modifier group, and it has a very impact on also pain and disability. The SVA, if it's more than 40 millimeters, is classified as a modifier 0, from 40 to 95 plus 1. More than that is plus 2. So the multiple studies have looked at how efficient and how reliable and how valid these studies are. And once they did multiple intra-observers. So they found it quite, in general, they're quite significantly, there's a big agreement. So this makes this classification quite valid and quite reproducible. So in summary, there's a coalition clinical outcomes with radiological measurement together. It has a very high importance in sagittal malalignment in restoring and treating the patients. The primary parameters are identified are the SVA, pelvic tilt minus lumbar lordosis, and pelvic tilt. This is why surgical treatment to restore these parameters has been explored and been studied. And I guess that's it.
Thank you, Dr. Saleh. Thank you for sticking with the time.